Good morning. I am Pam Morgan. I originally worked at Cincinnati Children's for 35 years, and I retired from there last summer and couldn't not work. So I got another job at Dayton Children's, because when you're a pediatric nurse, you have to find another pediatric institution. So I have been working with the IBD team as well as the GI team and the surgical team at Dayton for the last year. And it's been amazing. So I'd like to thank the committee for inviting me to come, and thank you all for coming in and listening to what I have to say. This is a very, very, very interactive talk. So pay attention and answer all the questions, and then I'll give you all the right answers if you work with me here. So the very first thing that we're going to do is just talk about helicopter parents. Maybe. Which way do I make it go?
Big green there.
Okay. I have no disclosures. So, what's a helicopter parent? I need some ideas. What do you think they are? You can just shout it out.
Parents that hover, constantly there,
Uh-huh.
checking every move,
Parents that hover, constantly there, checking every move.
answer for their kids when you address the question to the kids.
Yep. Answer for their children. Anything else?
Even when they're 25, 30 years old.
Yeah. Disguising themselves. Wow, you guys have seen some good ones.
That's a good one.
Any other specific qualities that you would see about a helicopter family? Okay. So, according to the Oxford Dictionary, it's a noun, a parent who takes an overprotective and excessive interest in their child or their children. This originated in the 1980s. Yes, you can thank us baby boomers. From the notion of the parent who hovered over their child or their children. So now we're trying to do a little dissection of why this behavior happens. So why do parents hover? Give me a couple ideas. Control, okay. They're scared. What are they scared of? What else? Think of the dance moms, think of the soccer moms. It's like, what are those kinds of, why are they hovering and over involved in their kids?
They want to be sure your child gets their chance or their opportunities, they don't get left out.
Right. They want to do what's best for their child, no matter what. Anything else? They what? They feel guilty. Yep. Yeah. So as you can see, it's a lot about the parent. A lot about the parent. So you're right. They want their children to be safe. As a parent, we feel like that's our primary job, is to keep our kids safe. So this is the mom who puts the pillow at the bottom of the slide so little Bobby doesn't bump his head. You know, this is the mom who holds on to the hand of the child trying to learn how to do the balance beam. Every little movement could potentially be a fall, a scrape, a something. And so trying to prevent that at all cost is really what they want to do. The unfortunate piece is they don't see the downside effect, that if little Bobby doesn't figure out how to slow himself down on that slide, he's eventually going to go whizzing down there, crack the back of his head, and not know how to manage it. So I think that it's all very well intended, but we're protecting our kids to the point where they don't have critical thinking skills. They can't develop cause and effect kinds of reasoning on, if I get up on this too high and I don't know how to get down, then what am I going to do? So they don't know how to test themselves. And the other thing, parents just don't want to see their kids fail. It's like you don't want to see your child fail. It breaks your heart. They're sad. They don't feel good about themselves. They may or may not have worked very hard on a project, and then to see them fail, it truly is difficult as a parent to watch that. And so oftentimes, and some of us would be very supportive, and then some parents, they just kick it into high gear. And you're never going to fail again. I'm going to do that diorama for you, and we're going to get a PowerPoint put together for your kindergarten class. But it's like, it's very difficult. They do not want their kids to fail because it's hard. It's hard. Sometimes, and we're starting to get over into sort of a different type of parental need with this, parents' egos oftentimes get in the way. They identify who they are, their own personhood with their child's. And these are the families that I think sometimes we see in our clinics, because this chronic condition has put them into a relationship that they may or may not have ever been in before. It becomes very, very engrossed. And those are the families that we probably need to help the most. And then lastly, the dance moms, the soccer dads, they equate their child's success and failures with them. It's if you are successful, I'm successful. So you're going to get an A on that science paper because I'm going to write it for you. You're going to get an A on that diorama because I'm going to stay up all night and do it for you. Those are the things, because if you fail, then I'm going to look like a bad mom. So we do have a lot of very very emotional and need-based issues going on with helicopter parents. And it's not that they don't want to be good parents. They've taken something and gone it a little too far. And I think in general, in the last 20, 30 years, we've seen a lot of parents just doing regular child rearing in a different fashion, where we used to have, a tribe of mothers and sisters and aunts who would help us do this. A lot of us, are out on our own trying to figure out how to manage this, and sometimes we kind of lose our way. So here's my case study. So Allison is a 17-year-old young woman with Crohn's disease. She was diagnosed at 10. She's been doing really well for several years. She's on a maintenance medication that is working for her, and she is getting ready to go off to college. We are planning her upcoming visit, where the final visit before college. Now, when she comes back, we'll see her obviously, but this is kind of the big send-off. During our transition program, this was a patient that I worked with at Cincinnati Children's, and during our transition program, the expectation is, beginning at the age of 14, some part of every visit is done independently by the child with the provider. And it starts very small, but that's the expectation. We're trying to help these families both to be supportive of each other, but to also disengage. The problem with Allison is that her mother is having a very hard time with this model. Allison's mother is the Black Hawk of helicopter parents. She has got night vision goggles. She's got it all. And, and it's been not just a struggle for Allison and for her mom, it's been a real struggle for the care team, because we have systems, we have support, we know how to do this. But boy, she can put a roadblock in front of anything. So unfortunately, she was one of our toughest cases, and we didn't do well for her. She would start to complain and talk about how it was her daughter, and her daughter didn't know the things that she needed to know, and what if she missed a question, and what if she says something that I need to hear, and what if, and what if, and what if, and what if. And finally, the daughter would say, fine, she can come in, I don't care. Just let her come in. And the providers would it's going to be best for you if you let your, nope, just let her come in. Every single visit for her 4 years of high school was that way. So what we ended up doing was make a pact and said, this is the next visit, August 12th. You are going to go to college that next week. You need to come. You need to see a provider. You need to have an independent appointment because we need to talk about some additional things. And so mother agreed. Mother agreed. The daughter agreed. Healthcare team agreed. And we thought we were on the right track. What do you think happened? What do you think happened? Yeah. Yep, she was not happy about this. It's almost like, I don't know what you're talking about. So Allison and Mom came to the visit. They were waiting in the waiting room. Mom, interestingly, had to get up and go to the restroom. The nurse came out to get Allison and said, "Would you like for me to wait for your mom?" And Allison said, "No, I think it's best if you take me back." So Allison went back and got height, weight, got put into a room, started to see the provider. And Allison's mom comes to an empty waiting room. And you can only imagine the angst that you can see in this woman's face. She goes up to the registrar. "Where's Allison?" "Well, Mom, she's gone back to do part of her independent visit with the provider, and we'll take you back." And this is what we are supposed to say with every single one. "We will take you back as soon as the provider is done so that you can join them for the last half of the meeting." "No, I want to go now." "Well, I'm sorry, but this is her time, yada, yada, yada." "No, I want to go now." Started to get very heated, started to be very, very loud. And then this was my favorite. She got up to the window and put her hands on the window and started yelling, "Allison, where are you?" Yeah. And so the nurse had to come out of the room, go quietly into the waiting room, hold her hand, sit her down, quiet her down, let her know that we were not torturing her child, that her child was not telling the whole family history. I don't know what she thought was going to happen if they were separated. So, yeah, it did not go well. So we obviously failed this family. So what should have happened? How could have we potentially prevented this? How could we have done a better job? Come on. Right. Yeah. Yeah. Clearly, Mom had a lot of issues, Mom had a lot of issues, and we didn't provide enough support for that mom. What else? How else did we fail this family?
The kid should have been more independent in her care and knowing herself all along.
Right. And that's a good point, because we're not 100% sure that she doesn't know her care because she can't ever speak. So she may know what she needs to know, but we can't get that information out of her, because just like Mom has to be in the room, the mom's the talker and knows the color of the stool and how many she has a day. Anything else particularly interesting about this case? So here's what we should have done. In the transition program in Cincinnati, it is a multidisciplinary team. And once the diagnosis has been made, the families are met, they meet with each one of the team. And they meet because we need to have a unified presence that this is a team and this is how we're going to work together. It's not when you need a psychologist, we'll pull a psychologist in. It is the psychologist is part of our team. You will meet him or her. They will talk about some red flags, how they can be supportive. Same way with the dietitian. You will need my help. You and I are going to talk about diet. So this is what should have happened with this family at the very beginning. And we've learned from this and have had much better helicopter parenting, sort of, I don't know what you call that when they go into rehab, helicopter parent rehab. And we've had some better outcomes. But that is what we do now. We have an orientation day. It lasts for about 2 hours. All of the new diagnosed patients and families that were diagnosed in the last 3 months come, and all of our providers, multidisciplinary providers, go there. So we have a social worker, we have a psychologist, we have a financial advocate, a doctor, a nurse, a dietitian. And everybody talks about their role, how they will be interacting with each and every visit with this family, and then start talking about this transition and supporting the family and helping for the whole family to learn the disease, as well as the child learning their medications, being independent with, setting up follow-up appointments, being independent with, ordering their antibiotics, and then certainly being able to be independent for short periods of time initially, but eventually being independent in a visit with a provider. Because at 18, you need to know how to do that. And we do. We start slow. At first, the expectation is, Bobby, how are you feeling? Mom barks in. Bobby feels fine, but it's, and it's like, no. Bobby, how do you feel? And finally, Bobby pulls his head up out of his hoodie and gives us a 5-minute answer. So it's like constantly trying to draw it out, but we start very slow. It is very, very nurturing, and we do it very casually. And then we really reinforce at each visit the why of investing in it and investing in the kids learning their care and investing in the parents. There's some great literature out there. Even the slide mom, with the pillow at the bottom of the slide, her poor child is never going to be able to figure out, if I go too high and there's no pillow there, I'm going to crack my bottom or my head. It's like they have to learn to test, and they have to learn to fail, and then they have to put that cause and effect together so that the next time there's a safety issue that's bigger, they know how to handle it. There is a lot of information in adult psychology, when I was looking through this, about the percentage of young adult college students who are depressed, who have anxiety, who feel that they are overwhelmed by the commitments of the college education. And why is that? Mom's not making their diorama. Mom is not putting together their PowerPoint. It's like they've never had to manage these multiple tasks to be successful. Mom has brought their, school to lunch. They've never had to go hungry. And so we're really creating a very anxious, not very successful group of young adults. So we talk about that. And then we begin preparing the patients for those independent visits. So first of all, it's, talking in the room, making sure that the child is talking and not the parent. Then setting the expectation in your August appointment, you're going to come back first, get height, weight measured, you're going to go into the room, the nurse is going to ask you the questions, and then your mom can come back. The next visit, you're going to go back, you're going to do the same thing. The physician's going to come in and do his questions. And so by the time we've gone through this, because most of them come every 6 months or so, by the time they're getting ready to go off to college, it's an expectation. They know what to expect. The families become much more comfortable with that separation, and we always give time for those conversations to happen, knowing good and well that mom's got a ream of questions to go over. That's fine, but we're hoping that her son or daughter were able to address a lot of this in the conversation, and then we can reinforce that. Bobby did bring that up, and here's what we talked about. So it takes a lot of energy, it takes a lot of time. The investment is well worth not having an Allison situation. And then we have to have support in place for both the parent and the patient. Sometimes the patient needs it more, and a lot of times the parent needs it more. And we oftentimes, once we get through the first couple visits after diagnosis, we will oftentimes have 2 sessions in a day. The first session is for the patient, and the second session is for the parent. We also encourage our parents to join the support group. They had Cincinnati has a support group called IB Devoted, and it's very active. They do a lot of social functions as families, and so it gives them that adult support and the kids the child support of being able to have normal lives, talking about things that they're very, very comfortable with. So, does anybody know where Allison went to school? Washington State. And she's doing very well. Well, thank you so much for your time.